In this video, we are going to learn about the cardiac output. Cardiac output is the amount of blood the heart pumps per minute. Its normal value is 5 to 6 liters per minute. So definition of the cardiac output is it is the amount of the blood pumped out by each ventricle in 1 minute. And cardiac output we calculate heart rate into stroke volume. You have to learn this formula. And heart rate is like 75 beats per minute, and stroke volume is 70 milliliters per beat. So the cardiac output comes to be 5.25 liters per minute. So we know that what is heart rate? Heart rate is the number of heartbeats per minute, right? And it is 75 beats per minute. Now, what is stroke volume? Stroke volume is the volume of the blood pumped out by one ventricle with each beat. So every time the heart beats, the amount of blood which is pumped out by each ventricle is known as stroke volume. Cardiac output, it is the blood pumped out by each ventricle in 1 minute. So when we multiply heart rate with the stroke volume, we get cardiac output. Normally, cardiac output is 5 to 6 liters in non-athletic people. Cardiac output, it can increase 4 to 5 times from this resting value of 5 liters. And in non-athletic people, it can go up to 20 to 25 liters per minute. So this is the maximal cardiac output. And in athletes, it can go up to 35 liters per minute. So the maximum cardiac output an athlete can have, it is 35 liters per minute. Under certain conditions, the cardiac output, it is increased. For example, if someone is doing an exercise, or if someone is in a stressful condition, heart, it can increase the cardiac output. So what is cardiac reserve? The difference between the resting and the maximal cardiac output is known as cardiac reserve. So in non-athletic people, it will be 20 minus 5, which equals to 15 liters per minute. Cardiac output changes, it increases or decreases if either or both stroke volume or heart rate is changed. So like I told you before, cardiac output is equal to heart rate into stroke volume. Now we can increase or decrease the cardiac output if the stroke volume increases or decreases, or the heart rate increases or decreases. So now let's go over the first factor, which is stroke volume. So how is the stroke volume regulated? Stroke volume we can calculate by end diastolic volume minus end systolic volume. Now what are these two terms? Now let's see, look at these two diagrams. So this is where the blood is coming into the heart. It is coming on the right side, and it is also coming on the left side. Now consider the ventricles only. So the ventricles, they fill up in the diastolic phase. What is the diastolic phase? It is the resting phase of the ventricle when the ventricles are filling. So at the end of the ventricular filling, the amount of blood which the ventricle has, it is known as end diastolic volume, and it is written like EDV. So this is end diastolic volume. It is the volume of blood which is present in the ventricle at the end of the diastolic phase. So this is the amount of blood volume which is available to the ventricle to push into the vessels. Now what happens that after that the ventricle's systolic phase starts. What is the systolic phase? That the ventricles, they contract, and the left side, it pushes the blood into the aorta, and the right side, it pushes the blood into the pulmonary trunk. But not all of the blood volume is pushed into the vessel. Yeah, after this systolic phase is over, a small amount of blood, it still remains in the ventricle. So there is small amount of blood in left ventricle, and small amount of blood, it is left in the right ventricle. This volume of blood which is still present in the ventricle after the systolic phase or after the contraction, this is known as end systolic volume. So now let's go back to our slide. Okay, now let's go over this formula again. Stroke volume is equal to end diastolic volume minus end systolic volume. And diastolic volume, it is affected by the length of the ventricular diastole and the venous pressure. And its value, it's calculated to be 120 milliliters per beat, because we have calculated the volumes in different parts of the heart. So the end diastolic volume is 120 milliliters per beat, and it is affected by the length of the ventricular diastole. What does that mean? The longer the ventricular diastole, the more the ventricle is getting time to fill up, the more will be the EDV. And the venous pressure, the more is the venous pressure, the more venous return there is, it will increase the end diastolic volume. And then end systolic volume, it is affected by the arterial blood pressure and the force of the ventricular contraction. What does that mean? It means that if the arterial pressure in the aorta, in this vessel or the pulmonary trunk is more, now the ventricle has to contract more strongly to push blood against that pressure. It has to overcome that pressure to push the blood. So if this blood pressure it increases, the pressure in the aorta increases, the end stroke volume it will increase, because heart will not be able to push that much blood into the aorta because of increased pressure in the aorta. And when the force of ventricular contraction increases, heart will be able to push more blood into the aorta, so end systolic volume will decrease. And the normal value of end systolic volume is 50 milliliters per beat. So now if we put these values in this formula, the normal stroke volume is equal to 120 milliliters minus 50 milliliters. It comes to be 70 milliliters per beat. Now let's see what are the factors which affect the stroke volume. There are three factors. There is preload, contractility, and afterload. What is preload? Preload is the volume of the blood which is coming into the heart. And afterload, it is the pressure in the vessels. For example, for left ventricle, it is the pressure in the aorta which the heart has to overcome. And then the third factor is the contractility. Now let's see. So preload, it is equal to the degree of stretch of the heart muscle. So what does this mean? The cardiac muscle, it exhibits a length tension relationship. At rest, the cardiac muscle cells are shorter than optimal length. And when the preload comes in, it leads to increase in the length of the muscle, and which leads to increase in the contractile force. So preload, it is the degree to which cardiac muscle cells are stretched just before they contract. And changes in preload, they cause changes in stroke volume. And how do they cause changes in stroke volume? Because the more preload there is, there will be more end diastolic volume. And relationship between preload and stroke volume, it is called Frank-Starling law of the heart. What is Frank-Starling law of the heart? It states that the heart will contract with greater force when preload is increased, and when it contracts with greater force, the SV, or the stroke volume, it will be increased too. So let me say again, the heart will contract with greater force when preload or end diastolic volume is increased, and it will increase the stroke volume as well. The most important factor in preload stretching of cardiac muscle is venous return. What is venous return? The amount of blood returning to the heart. Slow heartbeat and exercise, they increase the venous return. So when we exercise, the muscles they contract, and the muscles especially in the lower limbs they contract, and then as a result the venous return it is increased. And also when there is the heartbeat is slow, the ventricle it gets more time to fill, and the end diastolic volume it increases. Increased venous return distends the ventricles and increases the contraction force. So when there is increased venous return, there is increased end diastolic volume, and which leads to increased stroke volume due to increased contraction, and which leads to increased cardiac output. So this is a law that increased end diastolic volume will lead to increased stroke volume, and this law is known as Frank-Starling law. We have discussed the preload. Now the second factor which affects the stroke volume is the contractility. How do we define contractility? It is the contractile strength at given muscle length, and it is independent of the muscle stretch and the end diastolic volume. Increasing contractility, it lowers the end systolic volume, which makes sense because if heart it contracts with strength, the contractility is increased, it will be able to push more blood outside of the heart. So as a result, the end systolic volume will decrease. And what are the factors which increase contractility? They are sympathetic system, and we know the sympathetic system, the neurotransmitter is the epinephrine. And epinephrine, how does it do it? Epinephrine is also released by the adrenal medulla, and it is also released by the sympathetic nervous system. And epinephrine, it increases the calcium amount in the cardiomyocyte. So when there is more calcium present in the cardiac contractile muscle cell, it leads to more cross bridge formations between the actin and the myosin, and the contraction and the contractility increases. There are certain agents which increase contractility because we call them positive ionotropic agents. So ionotropic means increased, it means contractility, and positive ionotropic which have a positive effect on contractility. What are these factors? They are thyroxine, glucagon, epinephrine. Digitalis is a drug, and then high extracellular calcium. These all are positive ionotropic agents. They increase the contractility. Then there are certain negative ionotropic agents, which is acidosis. So acidosis is going to decrease contractility. Increased extracellular potassium is going to increase contractility. And then the calcium channel blocker drugs, they are also going to decrease the contractility. Why does potassium affect? Because potassium, remember, it has a very important role in membrane potential. Now let's see how norepinephrine it works. Norepinephrine, we know it is made up of amino acids, so it is a water soluble, and when it has its receptor on the outside of the membrane. Norepinephrine attaches to its receptor. The GDP is replaced with GTP. GTP, it activates adenylate cyclase. Adenylate cyclase converts ATP into cyclic AMP. Then that cyclic AMP is the second messenger. It turns inactive protein kinase into active protein kinase, which phosphorylates the calcium channels in the membrane and in the cytoplasmic reticulum. As a result, calcium comes into the cell from outside, and also it is released from the sarcoplasmic reticulum. And this increased calcium, it leads to increased calcium binding to the troponin, which causes increased cross bridge binding, and there is increased force of contraction. And now we have gone over preload and the contraction. Now the third and the contractility. Now the third factor which affects stroke volume is the afterload. What is afterload? Afterload is the pressure in the vessel against which the ventricle has to push blood, because ventricle, it has to overcome that pressure in the vessel to be able to push blood into that vessel. So afterload is the pressure that ventricles must overcome to eject blood. Back pressure from arterial blood pushing on the semilunar valves is major pressure. Okay? And then in the aorta, it is around 80 millimeters of mercury. In the pulmonary trunk, it is 10 millimeters of mercury. And hypertension, it increases the hyperload. How? Because when there is hypertension, there is increased blood pressure, increased pressure of blood in the aorta, and now the ventricle has to push against higher pressures. And as a result, the end systolic volume, it decreases, and it increases, more blood is left into the left ventricle. So just imagine that this is the blood which is left in the left ventricle. So the end systolic volume has increased. As a result, stroke volume decreases. We have gone over the factors which affect the stroke volume. Now let's see what are the factors which can affect the heart rate. Because cardiac output, it depends on both stroke volume and the heart rate. So if stroke volume decreases as a result of decreased blood volume or weakened heart, cardiac output can be maintained by increasing the heart rate and contractility. So positive chronotropic factors, they increase the heart rate, and negative chronotropic factors, they decrease the heart rate. So you have to know these two terms. Inotropic means which are affecting the contractility, chronotropic means which are affecting the heart rate. And heart rate can be regulated by the autonomic nervous system. Then there are certain chemicals, and then there are some other factors. Let's go over them. So how does autonomic nervous system? It regulates the heart rate. The sympathetic nervous system, which can be activated by the emotional or the physical stressors, it binds to the beta 1 adrenergic receptors on the heart, and it causes the pacemaker to fire more rapidly, which increases the heart rate. So sympathetic nervous system and the epinephrine, they increase the heart rate. And when the heart rate is increased, the end diastolic volume decreases. Why? Because the ventricle is not getting enough time to fill up. And then the other effect of the sympathetic nervous system, it is also on the contractility. It also increases the contractility. So sympathetic nervous system has positive chronotropic and positive inotropic effect, that it increases the contractility. When contractility is increased, the end systolic volume also decreases. So it is decreasing both the end diastolic volume and the end systolic, because both end diastolic volume and end systolic volume have decreased, the stroke volume can remain unchanged. So the sympathetic nervous system, it does not affect the stroke volume that much, although it increases the heart rate and it increases the contractility. But because it is affecting both the EDV and the ESV, the SV has remained unchanged. But sympathetic nervous system does another thing. When sympathetic nervous system is active, it inhibits the parasympathetic nervous system. And what does the parasympathetic nervous system do? Parasympathetic nervous system opposes sympathetic effects. So we know the neurotransmitter in the parasympathetic nervous system is the acetylcholine. It hyperpolarizes pacemaker cells by opening potassium channels, which slow the heart rate. So parasympathetic, it slows the heart rate, and it has little or no effect on the contractility. So you have to remember that both of these systems, parasympathetic and the sympathetic, they oppose each other. Under normal resting conditions, heart, it exhibits vagal tone. Parasympathetic is dominant influence on heart rate. It decreases the rate about 25 beats per minute. What does this mean? It means that if the vagus is cut and the parasympathetic effect on the heart is lost, the heart will beat 100 beats per minute. When sympathetic system is activated, parasympathetic is inhibited, and vice versa. So these both, they oppose each other, and this is how they can change the heart rate. And then there is another factor which is known as atrial brain bridge reflex. What is this? Sympathetic reflex initiated by increased venous return, hence increased atrial filling. So when the venous return is increased, the atria, they fill more, and as a result there is sympathetic reflex. And what is that? That the atrial walls are stretched with increased volume. They stimulate the SA node, which increases the heart rate. They also stimulate atrial stretch receptors that activate sympathetic reflexes. So in this way they increase the heart rate, and they also increase the contractility, and this is known as atrial brain bridge reflex. Now let's go over this diagram. This is from your Pearson text. So let's see what is happening. When a person does exercise, the cardiac output, it needs to be increased. How does that do it? So it can be increased. I'm going from down to above. So how can cardiac output be increased? It can be increased by increasing the stroke volume or by increasing the heart rate. So in exercise, both these effects are happening. So how is the stroke volume increased? It can be increased by increasing the end diastolic volume and decreasing the end systolic volume. And how can I increase the end diastolic volume? I can increase the end diastolic volume by increasing the venous return. And venous return can be increased by two factors. Exercise, it increases the sympathetic activity, and it also increases the skeletal muscle contractility, so there is more venous return. So when there is more venous return, there is more EDV or end diastolic volume, and thus stroke volume will increase. Now let's see, let's go over here that there is a decreased end systolic volume, and this increased end systolic volume is due to increased contractility. And why is this increased contractility? It is because of the epinephrine. Because of the effect of the epinephrine, the contractility has increased. As a result, the end systolic volume has decreased. So this results in increased stroke volume, which results in increased cardiac output. And now for the heart rate, we know that the neural effects, they are very important. So the increased sympathetic activity, it increases the heart rate, and decreased parasympathetic activity, it also increases the heart rate, because normally under resting condition the heart is under the parasympathetic influence, and when the sympathetic system is active, one of its effects is that it inhibits the parasympathetic nervous system. So parasympathetic nervous system is inhibited, sympathetic is activated. As a result, the heart rate increases and the cardiac output increases. So this is what happens when if I'm sitting and then I start to exercise. So these are the changes which happen. Now let's see what are the other factors. So we have discussed the first factor which affects the heart rate, which is the autonomic nervous system. And now there are some chemical regulators of the heart rate, which are hormones and ions. So which hormones, they affect the heart rate? Epinephrine, we know from the adrenal medulla, it increases the heart rate and contractility. Then there are thyroxine, increases the heart rate, and it also enhances the effect of norepinephrine and epinephrine. Then there are some ions, intra and extracellular ion concentration, for example calcium, potassium, they affect the heart rate, so they must be in the normal range. And electrolyte imbalance, it is very dangerous for the heart. The hypocalcemia, it depresses the heart, but if there is hypercalcemia, it increases the heart rate and contractility. So too much of both are dangerous. Similarly, hyperkalemia, it alters the electrical activity, which can lead to heart block and cardiac arrest. And hypokalemia, it results in feeble heartbeat and arrhythmias. So it is very important to have the electrolytes and the ions in the normal range. Now, what are the other factors? So far we have read that three factors, they affect the heart rate, autonomic nervous system, some chemicals which are hormones and ions, and then there are other factors. Those are age. Okay, so the fetus has fastest heart rate and it declines with age. Then gender, females, they have faster heart rates than male. Then exercise increases the heart rate, and trained athletes can have slower heart rate because they have trained themselves. And then the body temperature, heart rate increases with increased body temperature. All right, so this is just a summary of whatever we went through. Cardiac output, it is stroke volume into heart rate. And the stroke volume, it is affected by preload, contractility, and the afterload. And let's look at the preload. Preload, it means the venous return. When there is increased venous return, there is increased end diastolic volume. And then according to the Frank-Starling law, when there is increased end diastolic volume, the contractility increases and there is increased stroke volume. And the second factor is the contractility. Increased contractility, it leads to decreased end systolic volume, and it also increases the stroke volume, because stroke volume is equal to end diastolic volume minus end systolic volume. Then we have sympathetic nervous system. Sympathetic nervous system, it increases the contractility. Then we have certain agents which are known as positive inotropic agents. They also increase the contractility. And then we also have negative inotropic agents which decrease the contractility. Then the third factor is the afterload. Afterload is the pressure in the aorta and the pulmonary trunk against which the heart has to push. So increased afterload, it leads to increased end systolic volume, which decreases the stroke volume. So this is the effect of the afterload. Afterload is inversely proportional to the stroke volume. More afterload, less stroke volume. Then the other factor which affects the cardiac output is the heart rate. Heart rate, it is the main factor is the autonomic nervous system. So under normal condition, parasympathetic, there is vagal tone to the heart, which is parasympathetic nervous system, and so this decreases the heart rate. And when sympathetic nervous system is activated, it inhibits the parasympathetic and the vagal tone. As a result, the heart rate increases because the sympathetic nervous system, it increases it increases the heart rate, and but it increases both end diastolic volume and the end systolic volume. So the SV, it is unchanged, but because of its inhibiting effect on the parasympathetic, it increases the heart rate. And then there is another reflex which is known as atrial brain bridge reflex. What happens when the walls of the atria are stretched? They stimulate the SA node, and they also stimulate the sympathetic receptors. As a result, the heart rate is increased. Then we have certain chemicals which can increase the heart rate. There are some hormones and some ions, and then other factors are age, gender, temperature, exercise. And then you have to know this term. Positive chronotropic means factors which increase heart rate, negative chronotropic which decrease heart rate. And for contractility, the term is inotropic. Now let's see what can go wrong. So tachycardia, it is a condition when the heart beats more than 100 times per minute. So it is known as tachycardia, and if it persists, it can lead to fibrillation. Fibrillation is like irregular contractions of the ventricle, and it is very dangerous. Then what is bradycardia? Bradycardia is when heart rate is slower than 60 beats per minute, and it may result in grossly inadequate blood circulation in non-athletes, and it may be desirable result of endurance training, because the athletes, when they train, their heart rates, they are lower than than other people. And then what else can go wrong in the cardiac output? There is a condition known as congestive heart failure. It is a progressive condition, and the cardiac output is very low, so that the blood circulation is inadequate to meet the tissue need, and we say that the heart is going into congestive cardiac failure or congestive heart failure. And it reflects the weakened myocardium, which is caused by coronary atherosclerosis. What is coronary atherosclerosis? That the arteries which supply the heart, blood supply to the heart, the coronary arteries, those are clogged due to the fat buildup. And this impairs the oxygen delivery to the cardiac cells, and heart becomes hypoxic, and it contracts inefficiently, so its efficiency is decreased. And and congestive cardiac failure, it can be because of persistent high blood pressure, right? When there is high blood pressure, the heart has every time the heart beats, it has to uh, uh, contract against a very high pressure and push blood into the aorta. And the other, so there is chronic increase of end systolic volume. The heart is unable to push all the volume into the aorta, and end systolic volume it increases, and this causes myocardial hypertrophy and weakness because of the contraction, because heart is like it is doing what can you say, weight training. It is working against the aortic pressure, so there is hypertrophy, and also because then it is holding increased volume as well. So as a result, hypertrophy means that its substance, the thickness, it increases, and it causes weakness. Then multiple myocardial infarcts, that if someone has multiple heart attacks, the heart becomes weak because the contractile cells, they're replaced by the scar tissue, right? And then dilated cardiomyopathy, it is the ventricles, they stretch and become flabby, and the myocardium, it deteriorates. Remember, the myocardium is the muscular part of the cardiac of the heart wall. And then this dilated cardiomyopathy, it can be caused by certain drugs. So in congestive heart failure, it can start in either side. Either it can be the left heart or the right heart. So when the left heart it fails first, the left-sided failure results in pulmonary congestion, because now the heart is just remember, it is like the clog is happening at the back, because the left ventricle is unable to push the blood to the system. So there is increased end systolic volume. As a result, there is backup in the left atrium. As a result, there is a backup in the pulmonary circulation. So there is pulmonary congestion. Blood backs up in the lungs, and when there is right-sided heart failure, it results in peripheral congestion. Blood pools in the body organs, causing edema. Failure of either side ultimately weakens the other side as well.